I would like to take the chance and thank the organizers for kindly inviting me to this symposium. Most of us live happily for most of our lives with a pulmonary artery systolic pressure around, with a pulmonary artery systolic pressure around 25 millimeter of mercury and a mean pulmonary artery pressure way below 20 millimeter of mercury. However, a substantial number of people actually have higher mean pulmonary artery pressures, and if they exceed 25 millimeters of mercury, we diagnose them as patients with pulmonary hypertension. And this is far from being a rare disease. We don't have exact epidemiological data, surprisingly, but it is estimated that 1 in 100 patients or people in Western countries has pulmonary hypertension. This is not the case for pulmonary arterial hypertension, which we commonly think of, which indeed is a rare disease. But there are 4 other classifications of pulmonary hypertension, and these involve pulmonary hypertension due to left heart disease, which indeed is very common, and pulmonary hypertension due to lung diseases such as COPD and interstitial lung fibrosis, which again is very common. And just to mention the other classifications, we have chronic thromboembolic pulmonary hypertension, which is a bit more rare, and then we have miscellaneous diseases, which are indeed pretty rare. And what happens is that in pulmonary hypertension, we have a progressive remodeling of the pulmonary vasculature, which starts with a muscularization and an increased hypertrophy of the medial layer of the vessels, which then turns into a fibrotic process, and in the end, almost the complete lumen of the blood vessels is obstructed. So I was asked today to talk about adaptive, adverse, and reverse remodeling in pulmonary vascular resistance. So the question is there something like adaptive remodeling in pulmonary hypertension? And I think indeed, yes, there is, not in all cases, but probably in pulmonary hypertension with left heart disease. Patients with left heart disease, and this is a cohort with HFpEF here as compared to a cohort with systemic hypertension, have frequently pulmonary hypertension due to the backward congestion of blood from the left ventricle into the lungs. It's a reactive pulmonary, it's a passive pulmonary hypertension, and you see that here by the increased pulmonary artery systolic pressures. And that is associated with a remodeling in the pulmonary circulation. And you see here electron microscopic images of the alveolar capillary membrane in a control situation. These are animal experiments. And in an animal with left heart disease, you see this massive thickening of the alveolar capillary barrier of all layers here, the pneumocytes, the basal lamina, and the endothelial cells. And this thickening and restructuring is not limited to the alveolar capillary barrier. It goes all the way to the level of the individual cells. These are, again, animal experiments where you see a single microvessel here with a branch point where the endothelial cytoskeleton is labeled with a fluorescent dye. And you see how in a heart failure model, this endothelial cytoskeleton becomes much stronger and goes like a spiral around the vessel in order to stabilize it. The whole purpose of this remodeling is to protect the lung, which is exposed in left heart disease to increased hydrostatic pressures, from going into cardiogenic lung edema. So we have stabilized vessels, we have a thicker alveolar capillary membrane, therefore we reduce leak, we reduce water efflux, and that was nicely shown in an early study radiographically in patients by the efflux or the leak of radiolabeled indium into the lungs in control patients, where you see here the uptake of the signal, and in patients with severe mitral stenosis, where you see much less leak. And we can see the same again in animal experiments of left heart disease, where we can measure what we call a filtration coefficient. It's basically water permeability, which is similar in normal conditions between control and left heart disease animals. But if we expose them to higher pressures from the left ventricle, so if we simulate acute hydrostatic edema conditions, we see that the normal animals go right away into cardiogenic edema. We have this increased water permeability, but the animals which have adapted due to chronic left heart disease show a much reduced permeability. And we don't only leak less into the lungs in chronic heart disease. We also are better in absorbing fluid that has leaked into the alveolar space back into the interstitium. And that was shown in a nice study here where they measured alveolar fluid absorption out of the alveolar space, and you see in left heart disease it's increased. And this is attributable due to an increased activity of the sodium-potassium ATPase in the alveolar epithelium, which actively pumps sodium out of the alveolar space, and fluid follows passively due to an osmotic shift. So we have a lot of things going on in terms of adaptive remodeling in pulmonary hypertension with left heart disease, and all of them are targeted to reduce this situation to prevent cardiogenic edema formation. And I pointed out that we have interstitial remodeling, that we have cytoskeletal remodeling, we have reduced vascular permeability. What I didn't show is that we have also reduced an O response and an endothelial dysfunction, and that improves alveolar fluid clearance, which I mentioned. You may think endothelial dysfunction is a bad thing, which usually we look at it that way, but in left heart disease, actually endothelial dysfunction leads to a proximal vasoconstriction of the arterioles, and that reduces the hydrostatic pressure in the capillaries, and therefore, again, all of these work together in order to prevent cardiogenic edema formation. So a highly adaptive remodeling process, which actually makes a lot of sense. Unfortunately, it has a bad side effect that in the chronic situation, it develops pulmonary hypertension, not just as a passive pulmonary hypertension, but as a reactive disease. And then it's no longer an adaptive remodeling process, it's an adverse remodeling process. And we see that in the patients. This is again the HFpEF population. Now you see the pulmonary capillary wedge pressure plotted here against the pulmonary artery systolic pressure. You see that for a same capillary wedge pressure, so for a same level of congestion back into the lung, the HFpEF patients have higher pulmonary artery systolic pressure, meaning that these patients have reactive remodeling and increased PVR. This increased PVR, we can see that histologically. That's a study that we did with Ruben Tudor in Denver. This lung explained from a donor lung and from a lung transplantation with a patient with severe left heart disease. You see this massive thickening here in the blood vessel of the smooth muscle layer as well as the endothelial layer, the intima. And we also see that in autopsy cases of patients with left heart disease, again, the increased thickness of this medial layer here, that would be the normal range. All of them were increased, and that correlated actually with PVR values which had been measured prior to the patient's death. As a result of this adverse remodeling, now patients with left heart disease actually develop pulmonary hypertension, and as a result of pulmonary hypertension, they develop right ventricular failure. And you see in this study that the majority of patients with New York Heart Association class 3 or 4, 60% had not only reactive pulmonary hypertension, but actually severe right ventricular failure. And that is the major cause of death ultimately in this patient population. And you see that here patients with reactive pulmonary hypertension have a much higher mortality and reduced survival in the HFpEF cohort. That was all pulmonary hypertension with left heart disease. What about pulmonary arterial hypertension, what we generally think about when we talk about pulmonary hypertension? Well, as much as I scratched my head, I couldn't think of any reason why there would be adaptive remodeling in the pulmonary circulation under pulmonary arterial hypertension. It's really only adverse remodeling, and this adverse remodeling has various forms, and I'm trying to highlight a few here in brief, and starting with the left upper one, which I enlarged here so that you can see it a little bit better. One thing that we see in pulmonary arterial hypertension is a muscularization of these terminal precapillary arterioles, which generally only have a very small single smooth muscle layer, and now this muscular layer gets much thicker and they become muscularized. Yeah? And the origin of this muscularization was recently revealed in a basic science study, but I think it's one of the most beautiful studies, so I want to share it with you. It's from Daniel Greif. And what they did is they used a so-called rainbow mouse. A rainbow mouse expresses different colors randomly in different cells, in this case in smooth muscle cells. So some of them are red, some of them are yellow, some of them are blue, and you see that here in a histology of the pulmonary arterials that the different smooth muscle cells have different colors, and then the small precapillary arterials are not muscularized under control conditions. When you put these animals in hypoxia, they start to get pulmonary hypertension and their distal arterioles become muscularized. And the idea was, if this is a polyclonal expansion, so if all smooth muscle cells start to grow, then the resulting muscularization should also have all the different colors. If it's, however, a single progenitor cell, like a stem cell, which starts to proliferate, then it would just only be one of these cells which starts to grow, and the resulting muscularization would only have one color. And this is the result in chronic hypoxia. You see, that was muscularized before. This is the de novo muscularization. It's only red. It was a single cell, so like a stem cell, which was residing here, which reacted and started to muscularize this vessel. This is the same thing a few weeks later, after 3 weeks. This is actually beautifully a branch point where one vessel here has muscularized, originating from a red progenitor cell. One branch has muscularized, originating from a blue progenitor cells. And of course, if you measure overall, then the number of progenitor cells are equally for all colors. It doesn't matter which color was expressed originally, but it's only one progenitor cell which drives this process. In addition to this muscularization of the distal pulmonary arterioles, we also have an increased hyperplasia and hypertrophy, so a thickening of the vascular media here. And that's really driven by two processes. One is a proliferation of the smooth muscle cells in this vascular layer here, and you see that by an increased DNA synthesis in smooth muscle cells from patients with idiopathic pulmonary arterial hypertension, and increased cell proliferation as a number of cells over time, as well as an increased hypertrophy. So we have both proliferation and hypertrophy. Hypertrophy meaning there's more protein mass, particularly more contractile elements in these smooth muscle cells. And we see that as smooth muscle actin expression in age and sex matched samples from pulmonary arterial hypertension patients as compared to control patients in a study that we just recently published in the Blue Journal. In addition to this medial hypertrophy, we also have vascular stiffening. The upper picture here is again from an animal model of pulmonary hypertension that we took by chance, and we looked at this histology and we thought, this is strange. I mean, you see here the vascular media, these are smooth muscle cells, but what is this? Yeah? And I enlarged this for you to see that. And what does this look like? This looks like cartilage. Yeah? This is what a pathologist would call a chondroidal metaplasia. So it's a transdifferentiation of smooth muscle cells which become chondrocytes and start to produce cartilage tissue. Yeah? And so we have this massive stiffening of the vascular wall due to these processes. We have a similar thing for osteoblastic transformation. We get calcifications in pulmonary arteries of patients with idiopathic pulmonary hypertension. This is from a recent study published by Sébastien Bonnet, same name but not Damien Bonnet, but Sébastien Bonnet from Laval University, who showed here these calcifications in black, and beautifully the number of distal vessels which show these calcifications correlates almost linearly with 6-minute walking distance in the patients from whom these samples were taken prior to transplantation. We shouldn't look only at the vascular media, we also should spend some time to look at the intima, so what's happening at the endothelial cells. Why? because if we look at the amount of remodeling that we see in pulmonary arterial hypertension, yes, we see a thickening of the vascular media, but we see even more pronounced thickening here of the vascular intima. And what's considered to be happening at the level of the endothelial cells nowadays, and I just summarized this in this slide here, is that individual cells, because of an initial injurious stimulus, become apoptotic, so they undergo a programmed cell death. And this is a signal for the surviving cells to start to proliferate in an almost cancer-like process. And they grow into the vessel, and ultimately they almost occlude the complete lumen of the vessels. And this gives rise in the end to the so-called plexiform lesions, which are these very difficult to imagine structures where the endothelial cells grow like several skins of an onion inside the lumen of a vessel and obstruct it, and which is a pathognomonic histological sign of idiopathic pulmonary arterial hypertension. And you see that here, that these endothelial cells labeled here have completely obstructed the vascular lumen. What happens in the vascular adventitia? Just a few words to that. We have, surprisingly, and we only learned that over the last 5 to 10 years, a massive infiltration of inflammatory and immune cells in virtually all forms of pulmonary hypertension. And these include mast cells, macrophages, dendritic cells, as well as an abundance of B cells and T cells. And these B cells and T cells really form like lymph nodes, like tertiary lymphoid structures in the adventitia of the remodeled vessels. And you may think, why should they do that? Well, of course, we all know B cells, T cells are part of the adaptive immunity. B cells turn into plasma cells and produce antibodies. And indeed, this gives rise to autoimmunity. We find a lot of autoantibodies in many forms of pulmonary hypertension. And I summarized that here, a lot of anti-endothelial antibodies. This is joint work with Gabriela Riemekasten and Duska Dragun here in Berlin, where we identified anti-angiotensin type 1 and endothelin type A receptor antibodies, agonistic autoantibodies, which activate these receptors and again drive vascular remodeling. Well, if autoimmunity plays a role in pulmonary arterial hypertension, then targeted immunostrategies should maybe be beneficial. And at least that's true for animal experiments. This is a study that we did in an animal model, a rat model of pulmonary hypertension, the so-called monocrotaline model, which develops pulmonary hypertension and vascular remodeling if we deplete these animals of B cells by an anti-CD20 antibody. We protect them from developing the disease. The same is true for a specific rat strain, which does not express any B cell. It's devoid of B cells, cannot produce autoactive antibodies. And we could replicate the same in a second animal model of pulmonary hypertension, the Sugen hypoxia model. And this is actually going into patients these days. There is a big clinical trial in Stanford led by Mark Nichols, which is looking at the effect of a CD20 antibody as a neutralizing B cell depleting strategy for the treatment of pulmonary hypertension associated with systemic sclerosis. And as of now, there are 6 more patients to be enrolled in order to complete the study, and we're anxiously awaiting the results. Now, what about reverse remodeling? Can there be something like reverse remodeling? Well, the current paradigm, which is a hypothesis really, is that in the initial process of pulmonary hypertension, when we have this medial hypertrophy and inflammatory recruitment, the process is still reversible, which remains to be shown. We don't really know that. When we have metabolic shift, this phenotypic switching of the endothelial cells that I showed and the medial hyperplasia, it's considered that these cells now develop an epigenetic memory and that this process is irreversible. But we don't really know that. What we know is that pulmonary hypertension is reversible in the, oh, I forgot that. Do we have drugs actually for pulmonary hypertension reversibility? Well, this is our current drug treatment strategies, really, for pulmonary hypertension. And if you notice what we're doing here, we're blocking the endothelin pathway with endothelin receptor antagonists. We're using nitric oxide. We're using phosphodiesterase inhibitors. We're using prostacyclin. More recently, we're also using soluble guanylate cyclase stimulators. We're not even targeting remodeling, not to say reverse remodeling. We're targeting vasodilation, yeah, which is not the core of the disease, maybe in the initial phase. Yeah, we're light years away from reverse remodeling. And I said current treatment strategies. Please note that this is from 2004. We haven't made a lot of progress since then in terms of treatment options for pulmonary hypertension. But there is reverse remodeling in pulmonary hypertension with left heart disease. It's, I think, for the cardiac surgeons in the room, it's well known that if you transplant a patient with left heart disease and you look at this development of pulmonary vascular resistance over the years, it decreases substantially. Yeah? And the same is true if you mechanically unload these patients with left ventricular assist devices. So if you reduce the mechanical, the hemodynamic load, you can have reverse remodeling. And because it's the Lange Symposium, I thought I include a pediatric case here also, which was published a few years ago, of a 2-year-old who had biventricular decompensated heart failure, had a pulmonary vascular resistance of 16.5 Wood units, so massive, got a ventricular assist device. After 11 months, his pulmonary vascular resistance was below 3 Wood units. So massive reverse remodeling, of course, in a young patient where the vasculature is certainly more plastic. What about reverse remodeling in adults with pulmonary arterial hypertension? There was a lot of hope a few years ago on the use of tyrosine kinase inhibitors, which came from the cancer field, such as imatinib or sorafenib. That was the first description here of a single case report. There were a few more in the subsequent years. This was by Ardi Gofrani on a patient who progressively increased in his functional class of heart failure and reduced in functionality 6-minute walking distance on a maximal combination therapy of iloprost, sildenafil, and bosentan. And then they started him on the tyrosine kinase inhibitor, and boom, you see his pulmonary vascular resistance went right down, his functionality improved, and even his functional class decreased again. Sounds great. 10 years later, Ardi Gofrani and collaborators published the safety and efficacy study on the use of imatinib in pulmonary arterial hypertension. That's the conclusion from this study. Severe adverse events, significant side effects, and a high discontinuation rate limit the utility of imatinib in the treatment. The off-label use of this compound is discouraged. So the bottom line is, for pulmonary hypertension, if we start with pulmonary hypertension with left heart disease, we have adaptive remodeling and we have adverse remodeling, which makes the pharmacological treatment of this disease so difficult, because you want to preserve the adaptive remodeling. You don't want to drive your patients into cardiogenic pulmonary edema, but you want to reverse or reduce the adverse remodeling and increase right ventricular function. Right, reverse remodeling can happen if we hemodynamically unload the patient with an assist device or by heart transplantation. In pulmonary arterial hypertension, the situation is more bleak. I don't think we have any adaptive remodeling. We only have adverse remodeling, and we have no strategy whatsoever at the moment. We have some data from animal experiments, but nothing that has really translated into clinics to target or even reverse remodeling. And I think what we should do, and what we haven't done so far, is to leverage on this effect here. If we understand how improved hemodynamics can reverse remodeling in pulmonary hypertension with left heart disease, maybe it may provide us with some new targets and tools to also try to reverse remodeling in pulmonary arterial hypertension, but that's my personal opinion and a speculation. Thank you very much for your attention.